So given that this is a flash webinar, what we are going to figure out how to get the slides up and troubleshoot our technical difficulties. But in the meantime, I will get started saying thank you everyone for joining. I'll tell you briefly about Cerner Strategies if you don't already know. We are a Washington, D.C. based healthcare consulting firm. We have, Krista and I combined have spent many, many decades in Washington, D.C. Krista, as you will see here from our presentation shortly, is a Medicaid expert. I focus more on the Medicare side of things, and we have a team of folks here with expertise in a range of different issue areas, including value-based care, digital health, health IT, interoperability, Medicare Advantage, Medicare payment, Medicaid, AI, and the list goes on. So we are delighted that you were able to join us here today. Even as we troubleshoot our technical difficulties in terms of getting the slides to show up. I will go ahead and jump into a little bit of background about the One Big Beautiful Bill, which is what we are all here today to discuss. As everyone, if you follow the news or and we do now see the screen, so we will get started here in just a second, although we see the full screen, Krista. So you may want to share a window. But as everyone followed the sort of path of the One Big Beautiful Bill here in Washington, D.C., it passed right before the 4th of July, shortly before the self-imposed deadline that President Trump and Congress set for themselves. It included many healthcare provisions. So today we will cover the Medicare impacts, the marketplace impacts, and the Medicaid impacts, as well as some of the broader health technology impacts. The Medicaid impacts, as you will hear soon, were the most significant, so we will try to spend as much time as we can there. And if you have further questions about some of the other markets, of course, please let us know. Looks like we have resolved some of our technical difficulties, so we will go ahead and see if we can get the slides to advance here. Looks like we're back off. If they don't come up in a minute here, we will figure out.
Sorry, guys. Sorry about this. Okay, can you see now?
Yes, it needs to go into presenter mode, but yes.
Okay, I think we're here.
And that, ladies and gentlemen, is what we call a filibuster in Washington, D.C.
Okay, so now we are at a 27-minute webinar. Okay, so as you know, and why you're here, is that the Congress passed and President Trump signed the One Big Beautiful Bill. So we are calling it the OBBB here in Washington. As you know, it was a slim margin, but it passed, and there were quite a few healthcare provisions, which we are going to go over today. So the key dates, the first thing we're going to just talk about is when all these things go into effect, because I guess one of the reasons that we wanted to hold this webinar is because I'm sure that you're hearing from different news sources, different levels of discussion of what is going to happen, and the dates are a critical part of that. So as many of you know, we've been working a long time here at Sirona and through the Alliance for Connected Care on the carve-out provisions for telehealth in the among health savings accounts, and that is actually retroactive back to December of 2024. So there will not be a break in no cost sharing for people with HSAs. The marketplace subsidies expire at the end of this year. They were not renewed as part of the OBBB. We have the Rural Health Fund, which you also heard a lot about, which we are going to talk about today, and that application is due at the end of December. The Medicaid eligibility rules are scheduled to go into effect at the end of December 2026. The work requirements, which I'm sure have heard a lot about, we're going to talk about, those rules are going to be due out by CMS in June of 26, and states have to begin by 2027, but they can also start earlier. And then there's a lot of SNAP provisions as well, which we have included in healthcare given food and nutrition, and those go into effect in 2028. So I wanted to put the Medicaid provisions in context because you are going to hear from Republicans and Democrats, different messaging. On the Republican side, there has been a significant increase in Medicaid growth over what we anticipated. So the raw spending, we had a 76% increase, and in actual growth rate, we had a 9% growth rate over 2021 and 22. And we were expecting a 5% to 6% growth rate. So that is driven a lot by enrollment. We had a very special time between 2020 and 2023 when people were not to be redetermined. And so there were not people leaving the rolls in Medicaid. So that left a lot of people on the rolls. And those people also got an enhanced federal match. So we went all the way up to a record of 94 million people in 2023. But the disenrollment started happening when people started getting redetermined finally. And so enrollment did drop by 15 million people. So when you think about the very large increases in Medicaid spending that we saw in those 3 years, it was heavily driven by enrollment. And there is some discussion out there that what the provisions in the OBBB were trying to do is take us back to what we originally anticipated Medicaid growth to be before the pandemic hit. So if we didn't have all that enrollment, if we didn't have the enhanced FMAP, what would have happened? And so what do we do to take us back to that original spending? The challenge is, even with these, with, I guess the challenge is we still have a lot of pressure in Medicaid that is not going away. And that is, we still have high enrollment, more than we expected. We have inflation, so prices have gone up on everything, including healthcare costs. Workforce shortages are driving a lot of the cost because we have to pay higher salaries to people in nursing homes. We have challenges in behavioral health, in primary care, and obstetrics. So paying those higher rates or paying those higher salaries because we do see workforce shortages across the board. And we see a lot of closures in rural hospitals. So given this high amount of pressure in Medicaid, the spending stayed high even after the disenrollment. It wasn't obviously as high as it was during the pandemic, but it remained higher than what we would have seen. So I think part of the motivation in thinking about the bill was, well, we've got to take us back to a more moderate spending increases. And I think what you hear on the other side is, yeah, this is going to mean a lot of people lose coverage and a lot of providers are going to drop out of Medicaid because of, again, of these ongoing unanticipated pressures. So the Medicaid provisions get at some of what I think people viewed as some of the things that were happening in Medicaid to try to keep the program, the providers afloat, and sort of gaming some of the provisions that we have in law. So provider taxes was one of them. So Congress reduced the safe harbor, used to be at 6%, but in expansion states. So I think a critical piece to remember here is they just froze provider taxes in non-expansion states, but in expansion states, they reduced the provider tax safe harbor down to 3.5%. It's a gradual decrease. And lots of states have provider taxes, but this is really going to impact the expansion states. State-directed payments upon enactment. These are the state-directed payments are payments that are paid by the state through MCOs, so through the managed care plans to providers. So there's and it used to be that you could make an inpatient hospital or a nursing home whole up to a commercial rate. So you could pay them a higher rate, so they would take Medicaid patients and still be solvent. And now you can only pay them up to Medicare rates. So expansion states, you can go up to 100%, and non-expansion states up to 110%. So again, keeping in mind that there's a big difference here between expansion states and non-expansion states. Work requirements. It is mandatory for states to implement work requirements. Here at Sorona, we looked into, okay, well, what's the difference between the mandatory expansion of subsidies or expansion during the ACA, and what we're doing now, which is making states implement work requirements. And the difference is that this is a condition of eligibility, which Congress has the authority to do. So they have made it a condition of eligibility for Medicaid to work or engage in community service. There's a lot of exceptions, but those rules will be out in June of 26. And then finally, there will be a redetermination of Medicaid expansion population every 6 months instead of every 12 months. And there will be new cost sharing up to $35 per service in Medicaid. Previously, the cost sharing was basically just 5% of your family's annual income. So the savings from these provisions is significant. CBO and the Joint Committee on Taxation said about $1 trillion in savings over 10 years from Medicaid. You can see here on the right-hand side what each provision will save. The $7.4 billion in cost sharing, that is going to be avoided services. So it's not people paying their $35, it's people just not getting services. And so it will reduce the spend of Medicaid by $7.4 billion, but also that is price sensitivity. So people, may not be accessing services that they need, or maybe they didn't need it. So, and then work requirements, $326 billion, the estimate reflects sort of the difficulty in some cases of the paperwork, but also, anyway, there's we probably don't have time for that in a flash webinar, but the implications in each of these things with lots of detail. This is meant to be an overview. So there are some increases in the bill. There's $1.9 billion for physician fee schedule increase for 2026. There's $50 billion for a rural healthcare transformation fund and the HSA provisions. So as I've mentioned, the big difference in many of these provisions is between expansion states and non-expansion states. The red dots indicate expansion states. So these are the states that are going to see increased redeterminations, decreased safe harbors for provider taxes. The differences are significant between the red dot states and the non-red dot states. So that's something really to keep in mind. And KFF has some really good charts on kind of where the savings are coming from. So as you can see here, work requirements is a big part of it, as well as the eligibility, new eligibility rules. Medicare provisions. Kristen, I'm going to ask you to talk about Medicare.
Yep, thanks everybody. So relatively early on in this process, the president and Congress committed to not including Medicare cuts in this reconciliation package. So Krista already mentioned that we did see a plus up on the physician fee schedule. So a 2.3% increase to the physician fee schedule for 2026. That, of course, does not do anything for the cuts that are in effect for 2025, but for 2026, there will be a 2% increase to the physician fee schedule. And this is a little bit unique because in general, when Congress has plussed up the fee schedule, they have done it after the final rule for that year has come out. And in this instance, we are still awaiting the physician fee schedule for 2026. So they already sort of preemptively and proactively acted to add money into the fee schedule that we should see any day now. They did also maintain a differential conversion factor to incentivize APM participation. These two provisions are different than what appeared in the House. So the House would have included a 75% update to the medical inflation factor for going forward, and then 10% after that. So what we see in the past bill is really more akin to what we have seen in previous legislative actions to add money into the fee schedule. There were two other Medicare provisions that you see here, one on Medicare coverage related to citizens and certain individuals with lawful permanent resident status, and those with temporary protected status, including refugees and asylees. So this impacts coverage for those populations. And then there was another provision that is really important to the rare disease community around expanding drug pricing negotiation exemptions for orphan drugs used to treat rare diseases. So the drug pricing negotiation provisions were relatively targeted and a slice of the healthcare industry, really important to a slice of the healthcare industry but not, huge sweeping overhaul of drug pricing negotiations or, the IRA authorities. The most significant Medicare proposal was something that was actually not included in the bill because of the overall size and cost of the reconciliation package. There will be mandatory Medicare cuts triggered by something passed in 2010, a separate law passed in 2010 called PAYGO. This is going to come into effect, I believe, would trigger potentially 500 million in Medicare cuts. And Congress has generally acted to waive these cuts in the past. Pretty hard to pass legislation here in Washington now, although congressional leadership has said that they do intend to have other legislative vehicles. We will have a government funding vehicle. So sort of TBD on whether they act to avert these Medicare cost cuts that would, of course, again, be triggered by the overall size of the bill. And then finally, also there's a separate provision in a previous bill called the Medicare Modernization Act that would trigger a Medicare funding warning, which would, result in some additional activity. So potentially a report to Congress and additional legislation around the costs associated with the Medicare provision. So most of the Medicare action, aside from this fee schedule provision, is actually triggered by previous laws that, previous laws that included a trigger when the legislation meets, certain spending targets, or when the Medicare program meets certain spending targets, certain things have to happen. And that's it for the Medicare section.
I should have mentioned that there were also immigration provisions in the Medicaid parts of the bill as well. But let's go to the Rural Health Transformation Fund. As you know, there was it was originally for 25 billion and they upped it to 50 billion to try to ameliorate the impact on rural health centers. And so this $50 billion is actually not going directly to rural hospitals. It's going to the states, and there is no requirement to send it to rural hospitals, but our assumption is it will be. It is emphasizing and prioritizing chronic disease prevention and technology-driven prevention. So our anticipation is that states will be working with rural hospitals and others to come up with a plan to apply for this. And the application deadline is December of 2026. If every single state applied, states would get a minimum of $500 million just for the 25 billion part of this. And then CMS has discretion to distribute the additional 25 billion based on how rural your state is. So there are some, basically some tests for how rural your state is, and then CMS will distribute it that way. So states could get a lot more than 500 million. It basically is, that's a minimum, and that's over a 5-year period. Digital health. So as I mentioned, health savings accounts were in a carve out for telehealth. This is something that we here have been working on for a very long time. And it was, in fact, pre-pandemic, where we were asking Congress to allow employers to offer discounted telehealth benefits to all of their employees, even their employees who have a high deductible plan coupled with an HSA. During the pandemic, that happened because people were being encouraged to use telehealth. And so an employer could offer for free telehealth benefits, but it was expiring. So the Congress made it permanent. So now employers can offer telehealth for first dollar coverage, even for employees who have an HSA. Kristen, you want to talk about AI?
Yes. So this is one of the most controversial provisions of the rule amongst many controversial provisions. That's saying something. So the House passed version of the bill, the first House passed version that then went to the Senate, included a 10-year moratorium on state regulation of AI. That did not pass the process rules, something we call the Byrd rule, that the Senate needed to meet. So the Senate attempted to modify the House AI moratorium to tie state regulation restrictions to a program called the BEAD program, which is an AI infrastructure program that states already draw funds down. So there's, I believe, 40-ish billion of dollars currently in the BEAD program. The Senate language would have added an additional 500 billion, and there would be restrictions placed on drawing down the additional 500 million of funding. This was the subject of much controversy, much discussion. Did the restrictions apply to the whole 41 billion? Did it only apply to 500 million? How would the states even draw down the money given, all of this? And would it even be effective? So it became too controversial and too difficult and was ultimately stripped out from the final bill with a vote of 99-1. So almost unanimously removed from the bill. Where we go from here, the actions shift to the states. So now the states are fully on notice that AI companies across the healthcare economy don't want to be regulated at the state level. Many states are, of course, already regulating. So advocates and technology companies will need to shift their work to the state level. And Sirona is engaged in that space, and we're happy to share information with anybody if you have questions or want to follow up with us on the state AI work.
One of the key things we think is going to be model legislation, putting together model legislation and bringing it to the states. Otherwise, we are going to have 50 different regulatory structures for AI, which I know that was what Congress was trying to avoid. But states are going to be doing their bill filings starting in November and December. And so we are hoping to help shepherd some model legislation that can at least make it a little bit more uniform across the states for what we're going to see on healthcare AI regulation. So I'm going to stop sharing my screen and answer one of the questions that we got about the Rural Health Fund. Normally when CMS puts together a funding opportunity announcement that goes along with something like this, it can take quite a while. But since the applications are due in December, and also because Congress put in a lot of the eligibility or the sort of the conditions that they want to see in it, I'm expecting that the funding opportunity announcement will come out pretty quickly, but quickly still means probably end of September, if I'm guessing, because it still has to go through a clearance process at HHS and OMB. So watch out for those. I highly encourage states to start planning for that now. Reach out to your rural hospital systems, reach out to technology providers, because again, they are going to be prioritizing emerging technologies and chronic disease management. So you'll want to come up with a plan that sort of includes the priorities that that Congress has set forth.
Krista, while we're on the topic of rural, do you want to say something about how the bill is expected to impact rural hospitals? There's been a lot of discussion about that.
Yes, rural hospitals disproportionately depend on Medicaid. The provider taxes as well. So if you were watching the debates, there was a lot of discussion of rural health and how we have many, many hospitals closing in rural areas. And if we cut Medicaid, how is that going to impact rural areas? So we are going to see closures of rural hospitals, even with this fund, because patients are coming in. But again, these don't go into effect right away. But I know that rural hospitals will be planning for lost revenue. So it is going to be important for states to, get their plans together on how they're going to use the Rural Health Fund. They bumped it up to $50 billion because they're trying to fill that hole specifically for rural areas. So I think states are going to have a big role in helping to shore up those, those hospitals using that $50 billion. One thing we did not mention is that there are also immigration rules that were in the bill that we didn't put into the key provisions, and there will be reduced FMAP penalties for any state that covers undocumented immigrants. So there will likely be more people who are coming in for charity care. So that might be something that also rural hospitals and urban hospitals too will have to deal with it. Is the December 2025 state deadline feasible? There are a lot of accelerated timelines in this piece of legislation. I think this administration in particular wants to really go fast and change the healthcare system quickly. And they've got a lot of very motivated people over at HHS. So they also don't sort of put out, they want to put out things quickly, as I mentioned. So I think it's possible. I think the funding opportunity announcement is possible. On model legislation, we're still working on all of the logistics of how that would work. Can you provide further detail on the Medicaid directed payment caps? Essentially, these the caps go into effect on enactment, so they are going to be in effect ASAP. I'm assuming there's going to be some guidance coming out. It's inpatient and nursing home, so the health plans will only be able to create a differential in payment between the Medicaid rate and the Medicare rate in expansion states. And in non-expansion states, it's 110% of the Medicare rate. So those will go down. We have 1 minute left.
One thing to note, we didn't really touch on marketplaces here. There is, of course, a looming deadline related to the marketplaces and the advanced premium tax credits and the subsidies. Those were not addressed in this bill. So there is an unless Congress addresses them separately before they expire at the end of the year, and probably even sooner so that they can be built into marketplace bids. We will see some pricing changes for marketplace offerings. And that, could also impact coverage for populations receiving coverage through the marketplace. Most of the marketplace provisions in this bill were relatively narrow and related to immigration. We're at time. Flash webinars go fast.
Sorry for the technical difficulties, guys. Thank you.
Thank you.